Hello everyone, this is Karan Multani from the Dean Meeking Eye Institute, and today I'd like to share a case that we performed in a patient who had traumatic injury resulting in loss of the crystalline lens approximately 1 year prior. The patient underwent pars plana vitrectomy along with repair of the corneal laceration. At this time, the patient was aphakic and a hard contact lens over refraction indicated 20/50 vision potential. Decision was made, therefore, to perform artificial iris implant with corneal transplant and scleral fixated IOL surgery. The artificial iris was trephined to approximately 10.5 millimeters using a handheld punch based on the preoperative white-to-white measurements, which were confirmed with intraoperative measurements. A 27 gauge needle was inserted above the artificial iris and used to pass the haptic of the intraocular lens through this tunnel so that the entire artificial iris IOL complex could be fixated using the intrascleral haptic fixation, aka the Yamane technique. The leading haptic is threaded through this tunnel and externalized. And the same technique is used for the trailing haptic. The CT Lucia lens is used in this case because of the forgiveness of the haptics, as we note that there is significant stress to the trailing haptic during this part of the maneuver. However, once this haptic is successfully externalized, there should be minimal additional stress since the intrascleral haptic fixation portion will be performed with an open sky. The haptics are adjusted to ascertain that the lens is in good position and the entire IOL iris complex is inspected, with additional manipulations being done to ensure that there is good centration of the IOL. Attention is now directed to this patient. The scleral fixation sites are marked 180 degrees apart, again 2 millimeters posterior to the limbus, in preparation for the Yamane fixation portion of this procedure. In this case, we've decided, because of the large penetrating keratoplasty that would be necessary, that we will pre-pass our scleral tunnel needles so that when we remove the host cornea, we can perform open sky manipulation of the entire IOL iris complex. A Fleringa ring is first placed on the eye, given that we are going to have significant open sky and to prevent hypotony. The calipers are used to mark the area of the diseased cornea, and an RK marker is used to place the area of the sutures. Two 27 gauge angle sclerotomies are created using the 27 gauge needles. These are passed into the eye and left in the eye until we will place the haptics of the IOL iris complex. The area of the diseased cornea is removed using a 7.5 vacuum trephine to perform trephination of the host cornea. A 15-degree blade is then used to enter the anterior chamber through the trephination site, and the host corneal button is removed using the right and left corneal scissors. We noted that the cornea was quite edematous at certain points, and so a 15-degree blade was used to remove areas of attachment. At this point, the open sky intrascleral haptic fixation maneuver is performed of the entire IOL iris complex. We noted that the leading haptic had difficulty going in, so we directed attention to the trailing haptic. and then the attention was redirected back to the leading haptic. Again, the PVDF haptics of this IOL were very helpful in this case, given the extreme gymnastics that are needed to get this entire complex into the eye safely. The haptics are melted and bulb is created, and the iris is adjusted until we are relatively happy with its position. The donor corneal button is placed onto the cornea and secured into place using 16 interrupted Tylenol nylon sutures. The graft-host junction was evaluated, found to be watertight. At the conclusion of this case, using a closed chamber technique, the haptics are further adjusted and manipulated until there is relatively good centration of the IOL iris complex. The Fillinger ring is removed and the case is concluded. Thank you for your kind attention.